and the daily variations other than looking for blood sugar, fasting, and the postprandial and the HbA1c. Now we can hear from Dr. Rakesh. He is the fellow of American College of Royal College of Physicians and Surgeons, College of Physicians and Surgeons of Bombay, RSSDA, then Treasurer, RSSDA Rajasthan, founder, Metabolic Society Jaipur, recipient of several awards on editorial and reviewer boards of various journals. He has got more than 50 publications. He is a principal investigator on several global phase 3 trials.
Thank you, Chairperson. And thanks Dr. Rakesh for inviting me for this talk. I am supposed to have advancements in diabetes management with a focus on CGM. So I'll start with the 4 pillars of diabetes management, which are diet, exercise, medicine, and then monitoring. So I'll have just one slide each about diet, exercise, and medicines, and then we'll focus on monitoring, specifically about CGM. So in diet, the change nowadays is that we are focusing more on a low carb and high protein diet. Weight loss is also a goal for management of diabetes nowadays. Earlier we were focusing only on glycemic control, but now most of the guidelines talk about weight management as one of the goals for managing a patient of diabetes. Diet charts are now getting more and more individualized and personalized based on the patient's comorbidities, patient's weight, his goals, preferences of diet, the regional variations in diet, and all these things. Now, which are available, you can use those mobile applications and they will give you a personalized or individualized diet chart. Artificial intelligence is also picking up and playing a good role in that. Now there are several applications using AI where you just mention the details about the patient, his weight, height, body mass index, diabetic or not, what is the preference of diet, veg, non-veg, North Indian, South Indian, and the AI program will instantly give you a tabular diet chart for that particular patient. Exercise, now earlier we were asking the patients to only go for moderate or brisk exercise for brisk walk for 45 minutes a day, but now we realize that there is importance of resistance training also, and that's why the focus is on a combination of aerobic as well as resistance exercises. Sarcopenia is getting recognized as a very important factor or risk factor for development of diabetes and other complications, and the sarcopenia prevention is now the goal, and that is why there is a focus on exercises by which we can which can start in the middle age and prevent the development of sarcopenia in elderly people. Again, there are mobile applications which are available which can guide a patient for the individualized exercise program suitable for that particular patient. AI again has a role here also. There are several studies which have shown that just the dietary advice or exercise advice given by artificial intelligence was as good as that given by a doctor or a healthcare professional. In medicines, again there are several advancements which have happened in the last 1 or 2 decades. The major change in the guidelines is now that in the India guidelines you see there is an equal weightage which is given to glycemic goals as well as weight management. Cardiovascular protection is one of the most important outcomes that we look for, and that is how we choose our drugs. Medicines are getting personalized, so in all the guidelines you will see that we decide the first line therapy, second line therapy based on the comorbidities that the patient has. Because the patient has got ASCVD, high risk ASCVD, heart failure or CKD, and based on that we personalize the medicine for the patients. Precision medicine is now coming up, so in addition to these there are several wearable devices which are available, so you get inputs from different devices and you can give a precision therapy for a particular patient. Newer drugs have been there in the market. We already have GLP-1 receptor agonist oral also, which is available with us. Dual agonist and triple agonists are also there in pipeline, and we'll probably soon have them in India also. Newer insulins, we have ultra-long-acting insulins, ultra-rapid-acting insulins, and now once weekly insulin will also be probably launched this year itself. AID devices, there are several developments. Now we have the latest one, which is the advanced hybrid closed-loop system, that is 780G, which is available in India. So now we come to monitoring part. In monitoring, earlier we were doing only SMBGs, now structured SMBG is possible because most of the glucometers which are available now, they are connected glucometers, so they can connect with the mobile application, and they can, if you do a structured SMBG which is 7 or 8 points SMBG, they can give a graph just like a CGM. So for the patient who can't go for CGM, who don't want to go for CGM, you can use a structured SMBG also. CGM, we'll talk about it in details in the next few slides. TIR is coming up as a new matrix. So for all the patients of diabetes, specifically those who are type 1 diabetes or those who are on intensive therapy with multiple doses of insulin, TIR is a metric which is now being validated as good as HbA1c. Continuous metabolic monitoring is the field which is coming up now. So in addition to glucose, you can also monitor other parameters like ketone bodies and some other parameters can be. So there are tools which are being developed in which the device itself will measure, in addition to glucose, they will measure ketone bodies and some other parameters. Wearable devices we are all using for different monitoring purposes, and again AI also has a role in monitoring also. So now I come to the topic that was given to me, which is focusing on continuous glucose monitoring. Now, what is CGM? So if you compare SMBG with CGM, the SMBG, if it is not done in a proper way, the patient, even if he does 4 or 5 times in a day, he might get 4 or 5 points of blood sugar levels. Overall is 24-hour glycemic profile, but that does not give the exact picture. So if you plot a line chart from these points, you might get a rough idea about the variations in his blood glucose levels, but you might still be missing several other glycemic excursions, highs or lows, which can only be picked up by a CGM if you don't do the structure SMBG properly. So here, as in this case, you can see that if we just measure 4 points of SMBG, we'll probably miss the patient who has spent more than 4 hours above 110, which can be seen from this area. So this was the time which is around 4 hours of period where the sugar levels were above 200, but these were not picked up by us. And then overall, if you look at the blood sugars which are above 140, he has spent around 13.5 hours out of the 24 hours in this range, but you can't pick up those values based on the SMBG alone, and that is why there is a role of CGM for such patients. So the advantage of doing CGM is that you can pick up the missed highs, missed lows. You can see the stability of the glucose levels throughout the 24 hours period. You can see the inter-day variability in that patient's profile. So these are all the things that you can get only by doing the CGM. So what are the components of a CGM? So every CGM device, they have a sensor. So the sensor goes in the subcu space, and here it starts measuring the interstitial fluid glucose levels. Then there is a transmitter that collects the data from the sensor and transmits it to the receiver. And there is a receiver which can be a device or can be a mobile application which will collect the data from the transmitter and display it on the screen. What is the mechanism? So basically, from the capillaries, the glucose goes inside the interstitial fluid space, and by using the CGMs, we measure the glucose levels in the ISF. And these are equal to the glucose levels in the blood. The difference is that there is a time lag. So there is a time lag of around 8 to 10 minutes. So the blood, the ISF glucose values may be delayed by 10 minutes if you compare with the capillary blood glucose values. In terms of mechanism, this is the microscopic structure of the sensor, diagram of that. So it has got several layers. So outside this layer, you have the glucose in the ISF. Then there is a semi-permeable membrane here. This membrane allows the glucose to enter inside and prevents the inner parts from damage by the other chemicals. Then inside there is an enzyme, that is glucose oxidase enzyme, which converts the glucose which works on the glucose, and then in that process hydrogen peroxide is produced. So hydrogen peroxide releases the electrons which generate electric current. That current is sensed by the electrodes, and that current is passed on to the transmitter. So the electric current which is generated here in this enzymatic process is the parameter by which you can find out the glucose values in the ISF. So when you use a patient on CGM, these are the hypothetical examples, but there are 2 patients who are having the A1C of 9, because we look at A1C just the average glycemic value. So it gives the average of glucose excursions over all the period of 3 months. But the average might be same for these 2 profiles because he has got higher highs and lower lows. So it doesn't give us the exact picture of the glycemic profile of the patient if you look at only A1C. That can be achieved only by doing a CGM. So the CGMs that are available in India, they usually work for around 14 days. So if you put a patient on a CGM sensor, he will have the glucose profile of each day, which is represented in a different color here. So for day 1 it might be red, day 2 it might be green, day 3 might be blue, and like that. So there are 14 graphs, each representing 1 day for 24 hours period. And then from all these graphs, they plot a modal plot, which is basically calculated based on the values at a particular point on different days. So say if we look at the value at 12 midnight, so the value range from something around 250 to 50 also. So this was the range. The maximum values might be somewhere around 150. So 150 is the median value here, and then there are some variations. So these are the interquartile range. So maximum values are in this particular line, which is the median line, and there is the interquartile range. Some values were there, and there are rare values which are beyond that. That is the 10 percentile and the 98 percentile. So that is the AGM graph. So in the field of monitoring, from the 7-point SMBG, now we have moved to a typical CGM profile where you get the multiple points throughout the day, and then the ambulatory glucose profile, which is AGP, where you get a model plot from the average of 14 days. So this is the advantage of doing CGM. Now, what are the different types of CGM? So, typically the first one that was available to us for the last few years is the professional CGM, which is supposed to be used by the professionals, like the healthcare professionals. So, Liberate Pro was the one that was introduced in our market. With this sensor, it was expected that we apply the sensor to the patient goes home, comes back to us after 14 days, and then we collect the data from the patient using the reader. But then we found out some jugards and people try using some applications by which they try to use it as a independently scanned CGM, though it is not recommended. So professional CGM is a blinded CGM. The patient is not supposed to see the data of that. He cannot see the data. The patient comes back after 14 days and then the data is analyzed afterwards. Then came the independently scanned CGMs, which are now available. That is Liberate, which is available in India also. So this will measure the glucose levels continuously, but it needs to be scanned. So whenever the reader scans the sensor, that time the patient will see the glucose values. Otherwise, it will not see, and you need to scan it independently. So at least 8 hourly, you have to use the scanner for this particular sensor if you need to correct the data. And then there are real-time CGMs. So it is not available in India from the Liberate now, or the Abbott now, but there is one new player which has come up, that is ICANN, which is now available in India. That's a real-time CGM. It works through Bluetooth, so you pair it with your mobile device, and it will not only sense the glucose levels continuously, it will also show that levels on the mobile application. It also has the alarms. So these are the 3 major types of CGM devices. In addition, there can be another classification in which these are the CGM devices which are wearable, and there are implantable CGM devices which are not available in India right now, where the CGM is actually implanted under the skin and it works for around 6 months as of now. So the professional CGM devices, as I said earlier, here you collect the retrospective data. They typically last for 14 days, the ones which are available now. The data is not visible to the patients, and you need to download the data once the patient comes back to you for the visit. And ideally, you should do it for 14 days and then analyze data, then change the treatment. But again, as I said, for cost saving, we often call the patient after 7 days, we collect data and then we change the treatment and then again call the patient after 7 days, which is not ideal, because for getting an AGP graph, you need to have a data of at least 14 days. That is why a 14 days full profile should be done before making any changes in the therapy of the patient, which type of patient. For type 1s, it is not actually much useful. So what are the utilities of this professional CGM? One is that it is low cost. So the cost of the professional CGM is just around half the cost of the independently scanned CGM. It can give us, it can explain the discrepancy. So patient comes to you with a normal or high HbA1c, the SMG plot shows the normal readings. You're not sure whether the SMG is correct or the HbA1c is correct. Ask the patient to go for a CGM and it can pick up the highs and lows which might have been missed by the SMG. Then it gives us the information for therapy changes, particularly in type 2 patients. So it gives us the overall model plot of the patient for 14 days. You can find out which are the times when there is a peak and which are the times when the patient is going into hypos, and based on that you can make the changes in therapy. It is easy to for the patient to understand the overall model plot for the patients and the family members, and it is useful in the patients who either refuse to go for RT-CGM or who don't want to spend on that. So for those patients you can use this, but otherwise the real-time CGM or independently scanned CGM is the better choice. In professional CGM, patient don't need to do anything. You just put the sensor, the patient goes home, comes back after 14 days. There is no button on the patient, but in real time he has to scan the sensor himself. For type 2 patients, you can use this professional CGM once in 3 or 6 months. That is how it is cost effective. And the particular use of this particular CGM is in the clinical drug trials, where you want the patient to be blinded about the sugar readings. There you use the CGM so that the patient can't see the data of glucose himself. So broadly there are 2 categories. One is real-time CGM and the other one is independently scanned CGM. These are the two varieties which are used by the patients and recommended by the guidelines. Now, once the patient is put up on CGM, he comes back to you and then you put up download the data, upload it on the Libre view, and you get the report like this. So this is the AGP report of the patient, where you get the summary. So you will know what is the average value of the glucose, how much time did the patient spend in TIR or time above range or time below range, and then you can get the graph of individual days also. So for every day you have this particular graph where you get the average reading, average glucose value for that day, the time that the patient is spending in range or above range or below range, that can be seen, and the fluctuations and variations in the glucose can also be seen from the day-wise graph. And then there is the AGP, as I said earlier, which gives us the modal plot of the overall 24 hours. Here, three things are to be noted. One is the median line, then the interquartile line, and the interdocile line. So these are the three things that we need to interpret. So further the details about this will be there in the workshop, which is today in the afternoon at 3 p.m. Dr. Manoj Chawla will be explaining about the AGP interpretation also. So last two slides, these are the guidelines. So these are the targets for TIR for different categories. Patients with type 1, type 2, patients who are at high risk of hypoglycemia, need to be little liberal. Then patients who are type 1s or pregnant patients, you want to have the tighter goals. So these are the, there are different guidelines. Dr. Bansi sir, Dr. Jyotidev, these two people are the part of most of these guidelines on CGM. There are guidelines for India as well. So I think I'll stop here because my time is over and I have given the overview of CGM. There are other slides, but I think we can stop it here. Those who are interested in CGM, we have a special workshop on CGM, which is at 3 p.m. here only, and that will be a full 1 hour workshop. So we'll cover all the other details about CGM there. Thank you.